Please do not read this as Guillain-Barré. Okay, it's French, so we say it in French. Okay, Guillain-Barré, like ménage à trois, or okay. So Guillain-Barré syndrome. So what is it? It is a form of polyneuritis. It's autoimmune in nature. Just like any other autoimmune disorder, do we know what causes it?
You know what?
Do we know what causes it?
No.
Okay. However, it is precipitated by certain things. Okay. We know in all patients that get it, that develop it, something preceded the event. We'll get to that in the next paragraph. So what happens when you have Guillain-Barré syndrome? These are your symptoms. It's quite rapid, meaning you didn't have this yesterday, then you'll wake up with it this morning. Right? It's that fast. It's acute idiopathic polyneuritis. Acute rapid segmental demyelination, producing ascending weakness, and it's always bilateral. Okay, so both feet, both legs, it will go up. So there's weakness and then subsequently paralysis, meaning you get up one day, dangle over the side of the bed, and then you go push yourself up to get up, you'll fall on the floor because your legs have no strength. The antecedent, meaning what precedes the syndrome, is usually Campylobacter jejuni. That's a uh, form of bacterial infection. But most cases are preceded by some viral infection. Cytomegalovirus, Epstein virus, pneumonia, the flu. And interestingly, it's not just the flu infection, it also includes the flu vaccine, which makes sense, right? Because what are you given when you get the flu vaccine? An attenuated virus. So still makes sense that you had some form of viral infection before the event. So you develop it suddenly. There are many types, but the most common one is the first one, which is most prevalent. I've only seen one patient with Guillain-Barré syndrome. A big guy, cannot stand at all. He would just fall on his face. We did have one case, one former instructor here. She has since been disabled because of this, because after it resolved, she developed another form of polyneuritis after Guillain-Barré syndrome. And so she's on disability now. These are the complications that result in it because the patient is paralyzed, so therefore decreased mobility, they become bedbound, and some will have diaphragm involvement, which means they will have to be intubated and placed on a mechanical ventilator. Again, we don't know exactly how it works. We know that some viral event preceded the development of the condition, and then the patient developed antibodies and attacked and destroyed the myelin, the covering of your nerves. Manifestations, it always starts from the toes and up it goes. What's the sequence again? What's the pattern? Okay, from the toes and up it goes. With myasthenia gravis, where did it start? From the eyes, actually, right? From the eyes, then down. This one is from the toes and going up. Again, it's always symmetrical, bilateral, ascending, weakness, followed by paralysis. Respiratory failure results once it hits the diaphragm. As already mentioned, so 1 to 3 weeks before the symptoms begin, the patient had some form of viral event, including the flu vaccine. Then it peaks in 2 weeks. Because of this fact, the patient must seek medical attention for treatment within 2 weeks from presentation of symptoms. Because after 2 weeks, and then you go to the doctor, meaning you've had the symptoms for 2 weeks already, and then you came, there's nothing much they can do for you. Okay, the treatments, which is basically IVIG and plasmapheresis, will not work anymore. All right, so it's only effective if you present within what? Within 2 weeks. Now, why wouldn't people go seek attention for something like this, right? This is scary, right? You have weakness and paralysis, and it's acute. What do you think are the possible reasons? Finances. So some people do not have insurance. So let's say this is happening to a undocumented immigrant, for instance. Okay, so these are the marginalized people that are prohibited. You know, they are unable to seek medical attention for various reasons, or maybe elderly as well, or maybe the patient lives alone, right, and doesn't have much support. Yes, John?
Good question. For COVID, you wanted them? How updated this is? COVID, you wanted the virus in the
It is virus, so yes, that will qualify. Yeah, you could develop Guillain-Barré syndrome from, yeah, it's basically the viruses mentioned here. Although there is COVID update already here, and it didn't include COVID-19 virus, but I would say, yeah, it's possible. For diagnosing, there's not much blood tests or any scans that will prove or help us diagnose Guillain-Barré syndrome. So just like any other autoimmune disorder like lupus and myasthenia gravis and even rheumatoid arthritis, there wasn't a specific blood test, right? That singles out all of these conditions. So the testing mentioned here are more again done to rule out other possible causes. Okay, so let's say they want to do a CSF evaluation. They'll do a lumbar tap, get a cerebrospinal fluid sample to check, is this meningitis? Because some meningitis patients present this way as well. Treatment, like I said, 2 treatments here to, it's not really to cure the disorder, but to more like to shorten the period of the condition, meaning if it lasts for 6 months or 12 months, it's going to shorten the condition, the symptoms, for just a few weeks. Then you begin recovering. Most patients recover 100%. However, some, just like the instructor I shared, well, she did recover from GBS, but then she developed another polyneuritis, which is not typical. Don't get me wrong. Don't mean, you know, I'm not trying to say that you will never recover. Okay, so she's just one unfortunate individual that developed another form of polyneuritis. So it is a medical emergency because otherwise you will have symptoms going up to your diaphragm, and then you'll be on a ventilator. The other interventions here are for preventing complications of immobility, namely DVT, and then you get a PE. Here are the 2 treatments. It's or, okay? I know it says here, the statement says and, but it's not really given together. It's redundant, doesn't make sense. Between the 2, IVIG is very expensive. As I mentioned last semester, IVIG, immunoglobulin infusion, is sold per gram. Last time I checked, which was almost 10 years ago, the price was about $1,500 per gram. The dosing is based on your weight. So the heavier your weight, then the more your dose will be. So multiply that. So let's say I'm 70 kilograms. How much will I receive? 70 milligrams. And that's $1,500 per gram 10 years ago. Right? And it's not one infusion. It's a series of infusions over 2 weeks. All right, so that can reach millions, right? Easily. Okay. Therapeutic plasma exchange, this is like dialysis. So the machine is called an apheresis machine. The procedure is called plasmapheresis. So just like dialysis, what happens in dialysis? We put 2 needles in, and then what happens to your blood? Goes to the machine, and while in the machine, what does it take away? Waste products, electrolytes, and water, correct? What will the plasmapheresis machine remove? Plasma. Why plasma? Okay, so plasma contains 4 major things. Plasma is 70% water, 20% protein. It has clotting factors, and it has antibodies in there, among a few other things. What's the complication that could result from plasma exchange, from plasmapheresis? Because you're removing the patient's plasma and then replacing it with somebody else's. Bleeding, hypotension. What else? Infections, right? Because it has antibodies. Remember, not all antibodies in this patient's body are bad. Okay, there are good antibodies there too. So if you remove all of them, then the patient is at risk for infection. And because you're removing water and protein, blood pressure will drop. And because they lose clotting factors, the patient's at risk for bleeding. Right. So both therapies decrease circulating antibody levels. Again, the purpose of the treatment given within what time period again? Within 2 weeks from onset of symptoms, what will they do? It will reduce the amount of time the patient is immobilized, pretty much shortening the symptomatic period. And you will recover shortly after. As far as nursing process, these are basically preventing complications and pressure injuries related to immobility. As far as care for a patients with an artificial airway, because they are intubated and put on mechanical ventilator, we'll discuss that in module 5, okay? That's a separate chapter. Any questions on Guillain-Barré syndrome? That's it. Okay, let's go to we'll cover a few heat-related injuries. So we'll start with this chapter, and then we'll go back to the intra-op chapter because there's one heat-related condition there. So there are 3 here. We'll talk about heat exhaustion, which is not a medical emergency. Heat exhaustion is basically dehydration caused by heat exposure. Second is heat stroke, which is the true medical emergency. And then finally, hyperthermia, which is not the same as the 2 prior conditions. So let's differentiate heat exhaustion from heat stroke. Again, heat exhaustion is basically you're dehydrated because you're exposed to extreme heat. In heat stroke, the patient now has the same manifestations as heat exhaustion. However, the patient now has mental status changes, indicating brain injury. The temperature here for heat stroke is if you're exposed to temperature greater than 39.2 Celsius, or that's 102.5 Fahrenheit or higher, then the patients will begin manifesting first dehydration from the extreme heat, and then followed by manifestations of brain injury. Basically, your brain's being cooked. Okay. Let's start with prevention first. Although we're in the Northeast, we're not really that immune from heat anymore. So global warming has changed temperatures. So we're experiencing more and more heat waves in our region. So it's supposed to be this is just over the west side, right? On the deserts, but not anymore. So here are a few prevention. This can be a good select all that apply. I won't read it for you. So it's let's focus on our risk at-risk population. So who would you teach these? Who else? So very young, very old, yeah, seniors. Who else?
Hikers?
Well, with lupus, it's more for the exacerbation for days, but yeah, that definitely, yeah. Who else? What about our utility workers who are always outside, right? Okay, what about sports, athletes, right? Okay, so everybody who's pretty much outside, okay, working or uh doing outside recreation. So here are a few. Oh, stay hydrated, wear layered clothing rather than, one thick one. So that way you can just peel off a few layers as the temperature gets too hot. So here are the patients at risk. So good select all apply question, also very easy to answer. Now, heat stroke can be environment related, meaning we have a heat wave, or it could be also exertional. Temperature might just be mildly hot under 39 degrees, but when, let's say, there's a marathon, can that precipitate a heat stroke?
Yeah.
Yes, because now you have two, right? Environmental plus internal. Your exertion is going to raise your body temperature. Let's go to the manifestations. So if you're having heat stroke, again, the patient will manifest the same signs and symptoms as someone who is dehydrated. However, there is now profound central nervous system dysfunction. So patient will have confusion, delirium, bizarre behavior, or worse, they'll go into a coma, and then the acidosis will cause seizures. So the temperature, internal temperature, can reach 105 degrees Fahrenheit. So that's enough to cook an egg. It will cook the patient's brain as well. With anhydrosis, which is absence of sweating. Now, this is not always true because we have seen patients in heat stroke that are still sweating. It just depends on how much fluids do they have left. But most people present with no sweating anymore and the temperature is so high. With obviously the mental status changes already. Let's go to management. Now imagine, let's use an example of, say, Kurt is a marathon athlete. Okay, so he ran all the New York and Boston marathons. Okay, so he succumbed to the heat. He fell down. Now how do we take care of him? Okay, let's look at the textbook. So what's the main goal? We're going to reduce his body temperature as quickly as possible. So if needed, if he goes into cardiac arrest, of course, we do BLS followed by ACLS. So as far as reducing temperature, the following interventions are performed. So first is remove clothing. What type of heat loss is that? When we remove clothing? Because we have conduction, evaporation, convection, and radiation. So which one is that? We remove the clothing. Convection. Okay, so allowing, and radiation also, right? So allowing heat to dissipate, and then he's exposed to air now, so that's convection. So our goal is to reduce his temperature down to 102. So from 105 to now 102. At 102, we can handle that with non-aggressive measures now because we do have fever, right? Fevers can reach 102, but is this fever?
No.
This is not fever. So can we administer Tylenol?
No.
Tylenol will not work because this is not caused by a pyrogen. Okay, so his thermostat, his temperature set point in his hypothalamus did not change, unlike in an infection wherein the set point changed, right? So his set point remained at normal. He just generated so much heat that he cannot lose it anymore. So we have to help him out. So our goal again, what's the target? 102. Of course, we're gonna have that down to back to normal under 100.4. However, this just means that these aggressive measures we're doing, we're gonna keep doing it until when? until it reaches 102. Are we clear?
Mhm.
So once we reach 102, do we continue these aggressive?
No.
No more. So what are they? So one or more of these methods will be done. So is he at the hospital yet?
No.
No, he's still at the scene, right? We will bring him to the hospital, but we begin whatever we can at the scene. So first we'll remove his clothing, cool sheets or towels. Why doesn't it say here putting him in an ice bath? We put ice, however, only in these areas. So does this ever mention putting him in an ice bath?
And that will cause a shock.
Shock, I was gonna say that, don't you?
What will actually it trigger?
Ew.
Shivering, right? It will trigger shivering. So we don't want to cause shivering because that will generate more heat. Okay, so we do apply ice only in these areas. So what's with these areas? Why only these areas? They are rich in what do these areas? The neck, the groin. What do they have a lot of? Arteries. Okay, so they have a lot of blood vessels there. So we put ice in those areas so that will start cooling the blood. And we put cooling blankets and immerse the patient in cold. Again, do not use ice. Okay, so cold water bath, but not an ice bath. Okay, so we use other forms. So all of these are conduction, correct? So we do conduction, convection, radiation. However, we can reduce Kurt's temperature. Again, take care not to induce shivering. The temperature here, we will have to insert a thermometer inside his body, which means we'll have to put the probe in his rectum. The mouth here will not be advisable to monitor because what will he do with the probe? Remember, he has confusion, delirium. He will bite it. Plus, likely the temperature reading would not be accurate because of those reasons. So we'll insert the probe in his rectum. Plus, that gives you accurate reading, right? Because it's inside, it's internal reading. Although they mentioned bladder and esophagus, we've never done this actually in actual practice. Okay, so we do the rectum a lot. So the cooling process, anything will stop at 100.4. Okay, this is now considered right at normal. So that's enough. We stop everything at 100.4. All the while, we monitor for complications. This patient, can they develop rhabdomyolysis? Yes, because of all the extreme acidosis. Okay, pretty much because will this patient also have some lactic acidosis as well?
Yeah.
Yes, because remember, his muscles are not getting enough oxygen here. So seizure, watch for seizures. So always anticipate seizures. Some doctors will prescribe an infusion of levetiracetam, levetiracetam, a anti-seizure medication, as a precaution. And for fluids, because all heat stroke patients are dehydrated prior to the development of the heat stroke, so aggressive IV fluid therapy. No, isotonic. Now the IV bag may be cooled, meaning they'll wrap the IV bag with ice just to cool the IV fluid. Okay, so that will also help cool down the temperature. I mean, his body temperature internally. And we, of course, to evaluate our hydration, whether it's enough or not, we will have to put in a Foley to monitor early urine output. And if what type of AKI can result here from dehydration, severe dehydration? Pre, intra, or post? Pre-renal AKI can result. So that's another reason for the Foley to be inserted to monitor what stage of AKI he is at now, whether he's still oliguric or diuretic. Then for the acidosis that develops, we will have to give him sodium bicarbonate. Typically, at what pH again do we give sodium bicarb? Okay, so well, at usually around 7. Okay, if it's 7 or less, and we give sodium bicarbonate. Then we treat other symptoms. Now, careful with potassium because we don't really know at what point he will have hypokalemia. Because remember, when he hits oliguric phase of AKI, what will happen to his potassium? It will actually rise. If needed, if patient starts to shiver early while the temperature is still very high, 105, we still need to cool it down. These 2 drugs will be given to suppress shivering. They are benzodiazepines. And that's about it. Questions? Hopefully the patient, Kurt, did not suffer any brain damage from the event, and he should recover fully.
No, I lost it all.
All right, let's go to frostbite now. So from hyperthermia to frostbite. So this is the opposite. As far as risk factors, who are at risk for frostbite or hypothermia? Is it different from the people we mentioned earlier? Same people, okay? So same, yeah, not only utility workers, but homeless persons, right? Or mentally ill patients, alcoholics. We finished burns, so we know about the 4 levels of burn injury, correct? As far as depth, we had superficial thickness to partial thickness to full thickness, and then deep full thickness. It's similar to frostbite. So extremes of temperatures, really hot, or this one really cold, can do the same thing. It's not called burns though, it's now called frostbite. But either way, there is destruction of tissues. And it also depends on how many tissue layers were destroyed. So this is now the opposite. I don't have much for there's none for the degrees of frostbite, so I'm not testing that, at least not in this edition anymore. So these are the manifestations you'll see. The frequently affected body parts are the exposed cartilages, your nose, your ears, and then of course your hands and toes. So similar to burns, it can be 1st degree, which will appear red, to 4th degree, which is now black. So if it is to cool down, which is the goal for heat stroke and hyperthermia, this time we will warm the patient up. We remove constrictive clothing, which can impair circulation. We remove wet clothing because what will wet clothing do if they stay on the patient? Okay, the patient will never warm up. If the extremities are cold, we don't ambulate and we do not massage the affected extremities. What will massaging do? Do more tissue damage. So let's talk about rewarming now.
Like that, you can't. Don't do that.
Now, for rewarming, the rule is if the patient has a frostbitten body part, and that means where is this patient that they sustained a frostbite? Some remote area, right? Okay, because otherwise, if they were in the city, what is the likelihood of frostbite in the city? Okay, not much, right? Although it can happen. Again, homeless people are at risk. However, most frostbite cases happen in some remote area, right? Away from facilities, away from any buildings where they could seek shelter and warm up. So therefore, when should we start the pre-warming? At the scene, right? Okay, so the problem with that is if there's a risk that during transport, for instance, that the frozen body part which you're trying to thaw, if there's a risk that it will refreeze again, do not bother thawing. Do you understand? Okay, because you've seen steak that is freezer burn on steak, right? If you thaw that meat, what does it look like now?
Look black.
And then if you freeze that again,
No.
same idea. So therefore, if the patient's body part is frostbitten, and you think ahead that, oh, when we rewarm this and then we transport this patient, there's a chance it would refreeze again. So let's say the only transport you have is a what do you call those? No, the sports, the like a jet ski for ice. What do you call it? Snowmobiles. Okay, so those are open, right? So if that's your only transport to move the patient, will the body part freeze again?
Yeah.
Yes. So if that's the case, then don't bother. Don't start the rewarming. Okay, unless you have an ambulance. So yeah, go ahead and start rewarming. But if the transport vehicle is open, then do not bother starting the thawing, the rewarming process.
If you get indoors.
Correct. That way, when you rewarm, it's continuous. Okay? It's not interrupted, basically. So our goal to rewarm this. This is hot, right? 104 degrees. That's hot water. So that is the temperature of the bath water that you will immerse the frozen body part in, up to 104 degrees Fahrenheit. So that's
Feel it though.
Hmm?
The patient will feel it.
Well, this is painful when you rewarm. So the rule is, do you do pain medication?
Yes.
Yes. So that's another reason why we wait until we have the patient in a medical facility, because it's painful when you start to rewarm the body part. They will feel pain, extreme pain. So at least we have IV access. We can give the patient opioids before we begin the thawing procedure, the thawing process. So we put it in a circulating bath, basically like a whirlpool bath, 30 to 40 minutes at a time. Again, no massaging. That's not going to help. So once rewarmed, please protect it from further injury, especially from refreezing. We put them on a foot cradle. There will be hemorrhagic blebs, meaning blood-filled blisters on the frozen body part. And we treat other symptoms because the patient, of course, will also be dehydrated, correct? So we treat the patient. Tetanus will be administered just like in burn injury. We gave tetanus to the burn patients, right? So same here. For pain management, you can give NSAIDs and opioids at the same time. And these are the other interventions if needed, because this is basically a burn, okay, technically. So we can perform escharotomy as well, just like in burn injuries. If it involves a circumferential body part. Or fasciotomy. Let's talk about, and please read these. These are substances you have to avoid. what will these do? What is the effect of caffeine, alcohol? They are all vasoconstrictors. We don't want any further circulation compromise. Now, for hypothermia, which is when you have frostbite, that means you also have hypothermia, correct? I mean, how could you avoid hypothermia? Now, the rule here is because it's basically the whole body, which is cold, right? You should warm the core first, meaning warm the trunk first before warming the extremities. The reason for this is if you warm only the extremities, what will happen to the blood when it returns to the cold trunk? It's gonna get cold again. So therefore, you have to warm the trunk first, the central organs first. We're trying to prevent, what's the term? After something. Anyway, maybe we'll see it here. So the temperature here in hypothermia, the temperature reached below 95 Fahrenheit, you're officially hypothermic already. The contrary to what, let's say, especially Irishmen say, is they drink alcohol, right? Drink whiskey to feel warm. Yes, they feel warm, but what's actually the effect of alcohol? No, actually it causes vasodilation. So therefore, what will happen to your susceptibility to the cold will actually increase. So what else will put you at risk? Hypothyroidism or spinal cord injury. Again, same also as what we've identified under heat stroke. Okay, same patients. Let's go straight to management. So same thing as with the frostbite patient, we remove wet clothing, we start rewarming. Now the rewarming here would be internal as well as external warming. So if we can wrap the IV bags with ice to cool the patient down, what do we do with the IV bags when we give fluids to hypothermia patients? We warm them, so we wrap them with hot packs. That way they're warm when they enter the patient's veins. Yes.
If someone is drinking alcohol and they're bleeding, will the alcohol stop the bleeding or increase the bleeding?
No, because it's a vasodilator actually. Unless you pour the alcohol and then light a match, then yes, that will burn the blood vessels, stop the bleeding. So active rewarming methods, again, internal and external warming. If needed, the patient will be given lavage. You know what lavage is? We're going to put fluids inside your body cavities. So we can warm your stomach, or put NG tube in, put warm liquids into your stomach. We'll also put a rectal tube up your rectum, put warm liquids in there too. We can also irrigate your bladder. We put a 3-way Foley, irrigate you with warm, sterile, normal saline solutions. And then, of course, the warm IV fluids. Okay, so those are what we call internal warming methods. After drop, okay, that's the term. I forgot the term. Okay, so this is a significant drop. So please read this. Thank you for reading, Ms. Kirko.
As this blood returns to the core, it shows a significant drop in the core temperature after drop, and it can potentially usually cause cardiac arrhythmias and electrolyte disturbance.
Okay, are we clear? Which
Yeah.
body part again do we warm first? Start with the core first, start with the trunk, and then go toward the extremities. And this is the rationale why. So it's actually pretty serious. When you do chest compressions, you've learned this, right? In BLS, Jim? I mean, if the patient's body temperature is less than 95, and then let's say that you don't revive, they never come back, you don't have spontaneous return of circulation, do you stop CPR? No, you continue, okay? So we extend the CPR here because they say that you're not dead unless you're warm and dead. Does that make sense? Okay, so because what happens in, although you didn't do ACLS yet, but in ACLS, once you learn ACLS, so for our cardiac arrest patients, we actually induce hypothermia, meaning we cool them down. Okay, so that would not only decreases the metabolic rate of the patient, but also kind of preserves the heart. Does that make sense? So same thing here, the heart was kind of preserved. So the rule is you don't stop CPR until the body temperature is at least 96 Fahrenheit. So if they remain 95, that means they're still hypothermic. So they can't be pronounced dead yet, because you're only dead if you are warm and dead. So if you're still hypothermic, technically you're not dead. We continue chest compressions. All right. And the rest here are supportive, meaning we treat the patient's other symptoms. I already mentioned chest compressions if they go into cardiac arrest, which most of them do. And then intubate and mechanically ventilate. Discussions for which, again, we will discuss in module 5. And bicarbonate again, if the pH drops 7 or less. And for urinary catheter, same reasons. Okay, we monitor the effectiveness of fluid therapy. Any questions about the two? Okay, last hyperthermic topic is under intra-op. So go to chapter 15 under complications of anesthesia. Then we'll go on a break. So what is MH? This is a genetic condition. So a rare inherited muscle disorder. So what happens is you have this gene, let's just call it the malignant hyperthermia gene. Your muscles go into a generalized generalized contraction when exposed to anesthetic agents and neuromuscular blocking agents. I'll name the drugs associated with it shortly. Now, the condition can be identified with genetic testing. However, the testing is very expensive. Plus, what is the description? Extremely rare, right? So it's only here, 1 in every 170,698 people. So if you have 170,698 surgical patients, how many of them has the gene? Only one. You don't know which one. So are you going to test all of those 170,698? Not practical, not economically feasible, right? So what we'll do is we will just ask the patient questions. So this will come under because you have to prepare the patient before surgery, correct? You do an interview. So let's say Tenzing will ask the patient. Patient is Miss Peters. So Tenzin will say, oh, Miss Peters, okay, regarding your anesthesia, I have a few questions, okay? So question will go, have you or a family member had general anesthesia? Why do we ask that? Why you or the family? because it's inherited, okay? Meaning doesn't have to be Faith. It could be her parents or grandparents or her children. So we'll ask, have you had a reaction? If she says no, good. What if she says, I don't know?
Can you test that?
Again, the insurance company don't typically cover it because the insurance company will say, well, why? Yeah, why would I cover that? Hey, that you answer you continue asking the patient. So if the answer is no, okay. Have you had any surgery? So that's the next question. Okay, so if the answer was no, maybe no, maybe it's because they never had surgery. So in that case, we don't know. We have the data, and then anesthesiologist who administers the anesthetic agent will of course watch the patient carefully because we don't have any history. So we treat them as if they're high risk, right? Now, if the answer is yes, we'll try to ask, do you know what the reaction was? If the patient's answer is, I don't know, but they told me my dad had a reaction. We don't have to go into detail. We'll consider them as malignant hyperthermia. We consider, oh, that must have been malignant hyperthermia. In that case, then we will avoid these drugs mentioned here. So anesthetic agents are gas-based, right? They are inhaled anesthetic agents. So we will not use these. Are we clear? So we will use other types of anesthetic agents. Sorry?
Do we need to remember?
Yes, there's only 3 mentioned here. And this is not an anesthetic agent. This is a muscle paralyzer, you know, a neuromuscular blocking agent. Because you see, we receive three drugs when you're undergoing general surgery. So we're going to give you an anesthetic, which will make sure you don't feel anything. Second is we need to paralyze you because we can't have you picking your nose or scratching the surgical site during surgery, right? That wouldn't be good. So you're paralyzed, you can't feel anything. Finally, we're going to give you opioids so you don't feel pain. All right? Because even if you're not aware, you may still feel pain, correct? So those are the 3 drugs we typically give you. So what do we do again? If the patient's answer was yes, what will the anesthesiologist do? Not use these, yes, because we assume, okay, that must have been malignant hyperthermia. Okay, we can't take the risk. So we won't use these and we won't use this. There are other options. So why do we frequently use these drugs? Because they are the most cost efficient. They're the cheapest drugs on the market. Plus, again, what's the chance of this happening? Extremely rare. 1 in 170,000 patients. You follow so far? Now let's go to what actually happens to the patient. Okay. So when exposed to these drugs, it begins in the skeletal muscles. So now the skeletal muscles, and when I say skeletal muscles, it's every single skeletal muscle in the body will contract and never relax. So what will happen if muscles contract and never relax? Let's try it. Let's say here. Do this, you know, like contract this muscle and never let it go. Let's see how long you will last. Yeah, because this patient is not exercising, right? You're just laying there. But because of exposure to those drugs, it will trigger the reaction. It will cause every single muscle, skeletal muscle in their body from head to the toe to contract. You've seen videos on YouTube when they raise this patient's arm like that, it stays up. Put the leg up like that, it stays up. That's how the muscles contract. Okay, they never relax. All right, so that's what happens. So therefore, think of the amount of heat generated by all of these muscles. Will this cause hyperthermia? Contrary to the term, which is malignant hyperthermia, hyperthermia actually occurs later, meaning it's a late sign. By the time the patient has hypothermia, they're probably going to die already. So would you like to see that late sign or something sooner?
Sooner.
Okay, something earlier. Now, what else will these muscles consume or do besides generate heat? What are they also consuming? Oh, ATP and oxygen, right? They're consuming so much oxygen. So what do you think the earliest manifestation will be? Here's the first sign, tachycardia. Why tachycardia? When oxygen drops, what happens to the heart rate? Automatically triggers epinephrine release, right? Which causes tachycardia. So that's the sympathetic nervous stimulation. Now, which patient or which person in the medical team, in the surgical team, will notice this first? Or the patient's unconscious. The nurse is, well, depending on which nurse, because there's a circulating nurse and then there's the RN first assistant who is at the operating table. The anesthesiologist will first notice this, unless the anesthesiologist is in the bathroom. Okay, remember that. We need to know because who is going to be asked to watch the monitor if the anesthesiologist has to go to the bathroom? The RN, the RN circulator will watch. Are we clear? So that's why we need to know the signs, because what if it happens while they're in the can, right? So we need to know the symptoms. So when there's unexplained tachycardia, of course, there's tachycardia at some point, right? Because the patient's losing blood, correct? However, we do have IV fluids running. So the surgeon will give a verbal order, okay, increase the flow rate when they see increased bleeding, right? Okay, increase the IV, please. They'll say that. However, if there's an unexplained tachycardia, and what will happen to the oxygen level here? It will also unexplainably drop. I mean, it should not drop because the patient's on a ventilator. Okay, the patient is intubated on a mechanical ventilator on 100% FiO2. Why would the oxygen level drop? Okay, so these are one of the early symptoms. Again, early symptom is tachycardia followed by hypercapnia, which is high CO2. When you say high CO2, that means what's the oxygen? It must be low because can both CO2 and O2 be high at the same time?
No.
No, one is high, the other should be low. But you have your textbooks, right? Okay, please follow with me because the AirPlay is not working. So tachycardia first, followed by hypercapnia and hypoxemia. Okay, so blood oxygen drop, blood CO2 rise. And what else? So the muscles are breaking down, correct? So if they contract and never relax, so muscle cells will begin to die. So they will release what into the bloodstream? Lactic acid. What else? Can they release myoglobin as well? Yes, from the muscle cells. Will they release calcium? Okay, so all of these electrolytes will flood the bloodstream. So the patient, there will be rigidity. Okay, every single skeletal muscle will contract. There's now generalized muscle rigidity. And like I said, rise in temperature will be a late sign. So the temperature here will reach 107 degrees, sometimes up to 111. They're dead. That's why, again, do we let the temperature go that high? No. So once we see the early signs, which are again what? Tachycardia, hypercapnia.
Yeah, hypoxia.
Okay, hypoxemia or hypoxia result. What do we do? Okay, let's go to the action now. So what can we do? Well, it really depends. When did this start? That's that will determine whether the patient survives or not. When would be the best time for this to occur? Because when do they apply the anesthesia? When we're cutting?
No, right
No.
before.
Okay, so the patient's still on the table. Okay, the anesthesiologist, already has the IV site and then talk to the patient. Okay, we're gonna start now, okay? So they'll put the mask over the patient and then count down. Okay, 5, 4, 3, and then the patient stops counting because they're already out. So hopefully it starts right there. When we haven't cut the patient yet. But the problem is it can start at any point. So it could be right at the induction of anesthesia, or it could start in the middle. No, when you have the guts out and then we're really busy, that would be the worst time, right? Or it can also occur after the surgery is over. For this reason, even though it's rare, every operating room in the United States or worldwide actually has a malignant hyperthermia kit. It's a like any other surgical kit. So it's sterile, they wrap it. It's ready. Okay, and then they have like expiration date on it. The circulating nurses that's part of their job is to check, okay, when did this expire? Okay, we have one. Okay, so it should be ready. It's inside the operating room if we need it. But if you ask the RNs that work in the OR how many times they've seen it, the answer is probably, what is that? Yeah, 0. Okay, because it's extremely rare. Plus, you don't work 24/7, so may occur on another shift, not on yours. Okay, again, extremely rare. But do you want to have everything ready when it does occur? Yes, so that kit must be ready. So what does that kit contain? Everything you could possibly need when it occurs. So let's look at the patient's problems, and then what will we need to treat those conditions. So let's review. So the patient will have tachycardia, hypercapnia, hypoxia, and then what are the metabolic results? There's going to be hyperkalemia, correct? Because there's going to be acidosis, right? Lactic acidosis. So there's going to be hyperkalemia, and there's going to be hypercalcemia as well. All right. So therefore, and the drug to stop it, dantrolene sodium. This is the only FDA approved drug to stop the reaction. That will be in the kit. Okay, and there'll be fluids there. The only thing not there is ice. Of course, you can't keep ice in the kit; it'll melt. Okay, so the only thing missing is ice. Okay, but there's insulin in there. Okay, insulin with dextrose, which is for what? Hyperkalemia. Okay, very good. So everything you need again is in that kit, except for ice. So just grab ice. Okay. So let's say we identify it. Morris is the nurse. Okay, so she points it out. Hey, doctors, the patient's heart rate suddenly increased. The CO2 is 55. Oxygen is 60. Hello. Okay, so she'll say something like that. And then if possible, the first thing they'll do is here. So if possible, okay, anesthesia and surgery should be postponed. If possible. If not, then what can we do? Yeah, we're gonna have to treat it. Now, end-tidal CO2, we'll learn more about this. Let me explain this. This is measured with the probe. Okay, so let's say I have an endotracheal tube, right? You intubated me. Okay, Tenzin intubated me. So I have an endotracheal tube. So she'll put a sensor at the tip of my endotracheal tube. So when I exhale, it will detect the CO2. We call that end-tidal CO2. Okay, should be 35 to 45. So if it's high, and then my oxygen sensor is showing low, and then tachycardia, suspicious for MH, right? So you alert the anesthesiologist and the surgeon, and then we grab the kit, because again, everything we need is in there. Dantrolene sodium is in it. So you administer dantrolene sodium. This will begin to stop the reaction. It is a muscle relaxant, basically. We'll also need this when we get to MS later, multiple sclerosis. That will also be used as a treatment, but not, of course, not IM because it's available PO. So that will be administered to hopefully stop the reaction. If, however, we're already in the surgery, too late now, we'll just have to switch gases. Okay, so the patient's having a reaction and we can't stop. Okay, the patient's incision's already open. So the doctor will switch, anesthesiologist will switch. What were those three again? No, the anesthetics. Okay, halothane and fluorine, isoflurane. Scrap that. We'll use another gas, right? And then do we continue the infusion of succinylcholine? Change that also. Okay, go to ROC maybe, or another muscle paralyzer. That is if we're already in there, too late. We have to finish surgery, right? And then treat it at the same time. If the patient doesn't have a Foley, we'll have to put in a Foley. Why again? Because what will the myoglobin do? Because remember, there's myoglobinemia here. It will spill into the bloodstream, the myoglobin from the dead muscles. What will they do to the kidneys? It will cause intrarenal AKI. It will damage the kidneys. So we need to know, are the kidneys okay? Okay, we need a Foley. And then lots of IV fluids, of course. What else did we do? Okay, so patient has hyperkalemia, so we need to draw blood, right? Determine, okay, confirm hyperkalemia. What do we do? With what? Insulin with dextrose. Okay, so regular insulin with dextrose. How else? Let's say it's very high. It's not going to be enough. What else can we do? Calcium carbonate. Okay. What else? And then can we give sodium bicarb for the acidosis? Yes. Okay, so that's what we'll do. We'll administer those medications and then begin cooling the patient. Okay, because we can't wait. We know the temperature will rise. So begin wrapping the IV fluids with ice. Okay, if possible, wrap the patient with cold packs everywhere and then insert the probe. Okay, monitor the temperature. Is it working? Is the temperature holding? Okay, or is it rising? Because we know it will rise. Okay, until those muscles stop contracting, heat will continue to be produced. And hopefully the patient survives, right? That's what we want. Are we gonna ever do this again? Okay, please don't. Okay, so we will. Should this be marked as an allergy? Yes. What will we put in his allergy meds? Halothane.
Yeah, those.
Okay, correct. So these medications here, halothane, these are drug allergies, right? Yeah, basically an allergy because will we ever give these to him again? Never again. So halothane, enflurane, isoflurane, and succinylcholine will be on this patient's list of allergies.
Yeah.
And finally, because these are so rare, right? So every episode that happens is worthy of discussion, correct? It's an extremely rare condition. So therefore, we will report this to the Malignant Hyperthermia Association of America. Okay? So we can explore the conditions, okay? What did we miss? Okay, how could we have prevented this? Especially if the patient dies. Patient's dead, then it's a big issue, correct? Yes, question?
No.
All right, let's take a, yes.
Can this happen second time of using anesthesia? Like, let's say like I had 2 surgeries. The first time I didn't have reaction, but I have the second time. Or because it's a genetic disorder.
It's
stop.
genetic, so
You should stop.
it should have happened the first time already, upon exposure the first time. Because you don't just develop the genetic trait, out of nowhere, meaning you inherited it, you have it since birth. You just never have been exposed to that yet.